Imagine having this nagging throat pain that you just can't seem to get rid of. You go to your local doctor, he passes it off as acid reflux and sends you home with medications. Months pass by, you don't believe him, and you decide to go to a different doctor, a different hospital. That doctor decides to do a non-invasive, simple procedure right away to find the cause of this throat pain. And along the process, he finds a peach pit-sized tumor in your throat. And the only way to remove that tumor is to also remove your voice box, leaving you having to whisper for the rest of your life. And this is something that could have been completely prevented if the doctor before had simply done this procedure to rule it out earlier. But he is a human, and humans make mistakes. But it is what we learn from these mistakes that help us evolve our standards and progress to a safer healthcare system. Medical errors, by definition, are preventable adverse effects of care. So the 3 medical errors I'm here to inform you about today are retained foreign objects, inadequate monitoring of patients at risk for pressure ulcers, and wrong site surgeries. So these are delicate balances between life and death. Death can be imminent if these medical errors aren't caught soon enough, as pointed out in the story I just told you, and my story about Tom. Tom is a 12-year-old boy who had his appendix burst, but had a successful appendectomy. But a few days later after his procedure, he spiked a fever. They couldn't figure out why, so the surgeon decided to go in for a second procedure, but found the cause to be surgical sponge lodged in his abdominal cavity from his first procedure. This is not uncommon and actually most frequently happens in the abdominal and thoracic cavities. But we have come up with a system to count these post-operative sponges and instruments that we use. Guidelines make us count before we even cut into the patient to get a baseline, before you close up a cavity, inside a cavity, before you close up a wound, before you close up the skin, and then before all the nurses and doctors leave the operation room. Also, manufacturers of surgical sponges are forced to make their sponges with threads that are shown up in an x-ray machine, so they're more easily found. There have also been similar and tightly focused advances in protocols and guidelines for pressure ulcers as there are for retained foreign objects. So here's another example. Frank, a 72-year-old, was in a car accident where he broke his right leg. He was unable to move himself in bed or in a chair due to his age and this broken leg, so he was sent to a rehabilitation center. But weeks later, he developed huge gaping wounds in his right hip and his right heel. These became infected, and the physicians decided the only way to save Frank was to amputate his entire right leg. Pressure ulcers is what he had, and they are injuries to the skin or tissue over any bony prominence like your coccyx or your heel as a result of sitting on it for too long, which cuts off the blood flow, which does not give oxygen to the skin or tissue, which kills it off. So there are 60,000 deaths annually due to infections of pressure ulcers in hospitals. So the implemented strategies that we use are turning the patient every 2 hours, pressure distribution mattresses, and skin lotions and cleansers for incontinent patients, because incontinent patients are more at risk for pressure ulcers. My last preventable medical error are wrong site surgeries. So they are not on the decline as pressure ulcers are. They are actually on an increase according to a 2007 study. There were 15 by 1998, but now there have been 592 reported cases by 2007. The same thing happened to Bill. Bill was in a car crash where he had a seizure behind the wheel that led him to have both of his legs crushed. They found out that his left leg was salvageable, but his right leg wasn't. So after the x-ray technician took some photos, they sent him off to the OR. But the x-ray tech mislabeled the films and switched his left for his right. So instead of amputating his right leg, they amputated his perfectly fine left leg, which could have been highly preventable if a few simple steps of identification were taken. So our 2 safety goals with these are really, really simple. It's just identifying the patient by name and date of birth constantly, and having the patient and their family members witness you marking the surgical site with a big Sharpie marker, so it's visibly seen. So after listening to these 3 stories, it is important to remember how far our healthcare system has come in their effort to decrease and eventually completely eliminate medical errors. But these are never pinpointed to a single person. It is a system failure, but it is our duty to improve this entire system as a whole. To err is to human. It's human nature to make mistakes, but it's also human nature to innovate and create solutions to face these challenges head-on. There has been a huge amount of progress made in the last few decades in developing and implementing an action plans to prevent medical errors like the ones I just explained, the retained foreign objects, the pressure ulcers, and the wrong site surgeries. So with a combination of all these set guidelines and protocols, it's going to offer us this roadmap to a much safer and trustworthy health system.